Good afternoon, everyone. I am Barb Newman. Barb Newman, and I am a director in the surgical portfolio. This week, I've had the pleasure to be the team lead for RPIW number 19. Which was focused at the Pasqua Hospital emergency room, and it was from decision to discharge the patient from the emergency department without services to the patient leaving and being discharged from SCM, which is the electronic bed system. Our team will be reporting to a TAC time of 20 minutes. I'd like to introduce my team. This is probably one of the funnest teams I've ever had the opportunity to participate in. We have two of our leaders that after report out today will actually have, or be the first in Regina to have their certification as lean leaders, so we're really proud of Michael and Brent. We had representation from both of our emergency rooms by two incredible nurses. Their passion for servicing the clients and the real commitment to see their department grow and get better, we were just thrilled with. And our two patient representatives, they kept us on task this week, and we didn't look at anything but from the patient perspective, and they assured that we kept to that. I'll talk about our project form. We were in the medicine service line. Our senior sponsors were Dr. David McCutcheon, who is the vice president of the medicine service line, and Glenn Perchy, the emergency executive director. And we spent lots of time with our process owner, Jerry Bell, who's the manager of Pasqua Hospital Emergency. Our process flow at a really high level. Terry, in just a minute, will talk to you more in depth about that. From a patient's perspective, the physician makes the decision to discharge as a patient. For the patient, it starts with a wait. They see a care provider, they get some form of instruction, the patient leaves. And then there's a wait for that bed to be changed over for the next patient to be able to access it. What we saw in our current situation is with the process starting with the pushing what's called the PD button, the pending discharge. There was no really understanding of what, I don't want to say understanding, but there wasn't consistent use of how that button is used and when it was pushed. We quickly saw that there wasn't standard process that was being followed by any of the care providers for the discharge process for patients. Where we really focused and understood is that none of our patients were some were inconsistently getting verbal discharge instructions, but none were getting written. And then we identified there was cold bedtime because often patients would sneak out or leave and no one would recognize that, and so that bed would sit empty before it's removed from SCM and flagged to housekeeping to clean. Our target became very clear to us. It was on patient safety. From best practice, we heard from our patients and we heard from our emergency staff. Everybody felt really passionate that our patients deserved and required discharge care plan or instructions going home. I'm just going to do a quick overview of our baseline target progress report and just the things that we were able to affect during this week. Michael worked on a 5S in a filing cabinet which was really stuffed 190 different pockets of papers, and so we knew that we could certainly make an improvement for the emergency with that. And then because we really focused on our patient safety, we focused on our defects. And so with our quality goals, the two defects that we really hoped to attack were that patients that left the department with no change in their PD status, so that was essentially cold bedtime, that another patient could use that bed, and that patients that were not getting appropriate discharge instructions at discharge. And I'll turn it over to my sub-team lead, Terry.
I was fully prepared to trip on the cord, but I didn't. Good afternoon, everybody. I'm Terry Carlson. I'm an executive director in the clinical support services portfolio, and I'm short. Have you figured that out? I'm sub-team lead for RPIW 19, and actually this is my first RPIW, so it's been very interesting. I'm just going to talk to you a little bit about current state. We discovered our lead time for the patient to be 9 minutes and 35 seconds. We have an SCM lead time of 19 minutes and 35 seconds. We have to tell you that I think everybody was very surprised that our lead time was actually only 9 minutes and 35 seconds. We don't find that an inappropriate time frame. We did find a little bit of waste, about 35 seconds, which is fairly insignificant for our patient. What we really were focusing on was the 10-minute minimum. I guess it went up to 57 minutes sometimes, the cold bedtime. So when a patient actually left the bed, but we didn't indicate in SCM that they were gone and changed the status to dirty. So not so much of an issue for the patient in the bed, but certainly an issue for the patient in the waiting room. We developed 4 Kaizens out of this. The first one was really, we needed a definition of the PD, or pending discharge status, and some education around that for our professionals. We had a second Kaizen, which was standard work for the discharge process for the caregivers. The third Kaizen was about discharge information and the need for information sheets, generic instruction sheets, and then the fourth Kaizen was our 5S project. So TAC time, I'll just tell you a little bit about this. We had 24 hours in our day. Of course, it's a 24/7 department. We determined that we had 82 patients in our stream, and so I just want to be clear that we were only following patients that left the emergency department without services. Everyone other than that did not fall within our RPIW. What we determined is that we need a patient to leave our process every 17 minutes and 34 seconds to be able to stay on TAC time. We have some PQA data that we were able to gather, which was actually really good data that we got. A 9-month picture showed us an average of 116 patients per day leaving the emergency department or coming into the emergency department. I don't know if they all leave the same day. 3-month data showed us 82 patients fell within our stream. So that was patients that were discharged from the emergency department at the Pasqua, no services at all. Because of the RPIW 3, or the Kaizen 3, pardon me, we really felt it was important that we gathered the top 20 discharge diagnoses so that we could start to focus in on which instruction sheets we'd need or what data we needed. So we did gather that piece as well. We did a bit of a Pareto diagram, just wanting to really highlight that the majority of the patients coming out of the emergency department really did fall within our stream, so we think our work could be quite impactful. And I think I'm done. Thank you. Which one do I have left? Oh, just a second. I need that page. Strengths, weaknesses, opportunities, and threats. So strengths. When the PD button, pending discharge button, is pushed appropriately, our patient exits very timely. The staff in the department were excellent to us and very open and receptive, and it was a busy 4 weeks for them in there. We appreciate that. Weaknesses. We know for a fact that patients are not informed or communicated with consistently upon discharge. Opportunities, we really believe that if we increase the standard work and patient safety, it's going to be a better outcome, obviously, for our patients. And the threats, we felt strongly that when our patients leave and they don't have consistent discharge information or instructions, we leave them with less than perfect outcomes. So, thank you.
I'm Stephanie Langley, and I work at Pasqua Emergency. With the spaghetti map, we observed the nurse walking around a lot. It appeared chaotic. One of the biggest issues with staff was vital signs. There was no timeline on when vital signs should be done prior to discharge, so we've clarified that. Part of the time observation was keeping track of the steps the nurse took during the discharge process and timing that process. The standard of work combination sheet was completed and shown to what the nurse and patient were doing during the discharge process, and this gave us ideas to improve this.
My name is Kathy Bradford. I'm a volunteer participant on the committee representing patients and family. We used the ideas summary sheet and we spoke to staff, patients, to staff and patients. And the current status was that the PD and home button was pushed by various people at varying times, hence the picture you see there of the room not being cleaned. There was a suggestion that the nurses would do all discharges and provide written information, but the solution was the PD button would be pushed, it would show on the SCM board in striking teal blue, and the standard discharge form is now given to every patient when they leave, as well as pre-printed information for most common discharge diagnoses.
Good afternoon, everyone. My name is Ryan Perdue. I'm one of the nurses at the General Hospital Emergency Department. So first we had to actually define what the PD button actually meant, which was a bit of a challenge. Currently, before this process, the doctor hit the PD button when they felt the patient was medically ready for discharge. The nurse would go discharge that patient. They couldn't walk, they had pain, they didn't have the walker. There was tons of barriers why they couldn't leave. So now based on this, the doctor will hit that button when the patient is actually physically ready to leave the department, medically ready, socially ready to leave the department. Also, if the physician themselves is going to discharge the patient, then they're going to hit the DFC button. That will clear the bed off SCM, allow housekeeping to know that it needs to be cleaned, quicker turnaround in beds, get patients in beds quicker. If the nurse is going to discharge the patient, the physician will hit the PD button, lets the nurse know the patient has to go, and the nurse will take care of that. Second, we did a standard work process for the nurse, and that will give increased safety for the patient and efficiency for the nurse. Then we did a spaghetti map diagram for our process, then a time observation form, and the standard work combination form. Last but not least, we trained our frontline staff and showed 100% compliance. Thanks.
Good afternoon. I'm Mike Redenbach. I'm VP of Primary Healthcare. And I've enjoyed working with this team. It was a great week. So the percent load bar chart, as you can see, we are well within our TAC time. As Terry had noted earlier, 17 minutes and 34 seconds. So reducing the time wasn't our main goal as part of this RPIW, is improving the quality of the work and making sure that all patients had discharge instructions. So we expected and did experience that the time went up slightly from 240 to 282 seconds, but we don't consider that to be a failure in the part of our work. It was what we anticipated. So we did do a waste walk. This was begun by Barb and Terry in the preparatory weeks, and our team did this on Monday, and as you can see, identified a lot of different wastes, many of them outside the scope of the RPIW, but some of them on the wheel of waste there, PD button push before patient status ready, patient not being removed from SCM, patient with no discharge instructions, all of the ones that we've talked about addressing. So the 5S project that I was working on was a 4-drawer filing cabinet in the Pasqua Merge. You can see our pre-Kaizen score, not unusual for pre-5S areas. It was a 1.4. Because it was a filing cabinet, not all of the evaluation criteria were applied to this, but I'll tell you a little bit about what it is we were doing. So the looks okay from the outside. This filing cabinet contained not just the discharge instructions that was the focus of our RPIW. It included pre-printed orders, it included referral forms, it included administrative documents, it included papers that people had no idea what they were or why they were in there. So we 5S that. Here's another pre-5S photo. So aside from the types of documents and the volume of pieces of paper, the tabs were askew, some of the material was tattered, it was unsightly, so we looked at improving that as well. I talked about the amount of material that we took out. This photo is just the amount of paper from documents that should have been in there. So those all need to be in the filing cabinet, but you don't need 5,000 copies of it. And so some of these literally were 10 years worth of supplies of forms. So those were just the ones that were staying in the filing cabinet, but that was too many of them. There were others that we completely removed because they were located at other places in the department or they were just not used at all. So our main aspect of this was to make it easy for the staff to access the discharge instructions. So we moved them, instead of having them interspersed within all of the files, we put them in the top drawer of the filing cabinet, labeled it, color-coded it, put the tabs up there, and hopefully that will prove to be helpful to the staff. We also will provide them with a list of what's in the filing cabinet. Didn't have that in advance of the RPIW, so they will be able to update that, and I would suggest do further refinement to the filing cabinet and improve it for their own benefits. And so our post-5S score was a 2.6. We were, I think, relatively satisfied with that. There's supplies, equipment that's on top of the filing cabinet that we didn't really look at addressing as part of our little Kaizen, but that's something for the staff there to consider. And there's our post-RPIW wheel of waste. And as you can see, we made some inroads into addressing some of them as part of the RPIW, and there's others there that are for the group to consider later on. Thank you.
Good afternoon. I'm Brent Kitchen. I'm a participant in RPIW number 19, and I think we have about 3.5 minutes left. So I'll just quickly take you through our RPIW newspaper, highlight some of the things that is work really yet to be done. As Kathy talked about, we did change the PD icon on the SEM board to draw staff's attention to the fact that PD has been designated for a patient. There was some confusion that we discovered around the use of the stop sign icon that's used on the SEM board in emergency, and there's some work required to clarify what will be used as a signal to social work versus the stop sign icon. Staff are going to need to be updated on the new processes in place, and there's some training required for staff and physicians. So just quickly highlighting some of the target progress report and result sheet. If you, I think, really pay particular attention to our quality numbers and the numbers of defects, that really was a focus for the RPIW. That was really one of our key objectives, was to improve safety for the patients, to remove that defect, which we consider to be patients leaving without any discharge instructions or written discharge instructions. So you can see in point 2 at the bottom of the page that we managed to improve that to 100%. We witnessed 100% of patients leaving with written discharge instructions at the end of our RPIW. We did also improve by 85% the 5S score for that material that's provided to patients, that supplementary material aside from the discharge instruction sheet. And we did manage to decrease the cycle time by 50% in SCM. That's the time when the patient exits until SCM is updated. That's that cold bed time that we talked about. So that decreased by 50%. Thank you.
Good afternoon. I'm Russ Moore, and it was my pleasure to act as the representative of patients and their families during this workshop. So what did we accomplish? Well, we created standard work for the professionals within the emergency department. We created the emergency department discharge instruction sheet, and that sheet's to be given to all patients on discharge. And we also created specific information sheets for 8 specific diagnoses. We improved the visual cue for the pending discharge icon on the SCM board, highlighting with color. We 5S'd the patient resource material cabinet and updated all the contents of that cabinet. So in closing, on behalf of all the members of our team, I would like to thank Denise Merva, Carla Engel, Sue Schmidt, Shauna Lafreniere, the radiology department for the use of their conference room, Maggie Allen, all the ED staff and physicians for allowing us to interfere with their day and for cooperating with us in our work, Jerry Bell, Glenn Perchie, and Dr. McCutcheon. Thank you.